Now let's talk about cholelithiasis and related pathologies. Cholelithiasis, gallbladder lithiasis stones, GB stones, increase in cholesterol and or bilirubin. So wait, let's just go back a little bit. So there is a super saturation due to either one or more than one of these things. So supersaturation due to increase in cholesterol and or bilirubin, or decrease in bile salts, and gallbladder stasis, all causes a sludge or the stones. There are two types of stones. One is the cholesterol stones, looking at picture A, and the other is the pigmented stones. So the cholesterol stones are radiolucent. What do we mean by what is radiolucent? Radiolucent means they can't show on X-ray. So let me write X-ray, but they can't show on X-ray. That's radiolucent. And the other guy, which is radio-opaque, what do we mean by here? It shows on X-ray. So X-ray, yes. Okay. Radiolucent with 10 to 20% opaque, although they're saying it is radiolucent, you can't see them, but 10 to 20% you can't see them due to calcifications. 80% of the stones. Okay. Associated with obesity. What are the associated? Very important. Associated with cholesterol stones are associated with obesity, Crohn's disease, advanced age, estrogen therapy, multiparity, rapid weight loss, medications, for example, fibrates, race in the white and Native American population. Okay. While the pigmented stones, which are black, when they're black, you can see them on X-ray. So calcium bilirubinate. So the wait, let me erase this. What do we have here? Black equals radio-opaque, calcium bilirubinate stones, hemolysis. If you have a black stones in pigmented, or you have whatever brown stones in pigmented, the black stones are radio-opaque, and they are formed by the calcium bilirubinate and hemolysis. Browns are radiolucent. What was radiolucent? No X-ray. And infections associated with, so all of them are associated with Crohn's disease, hemolysis, alcoholic cirrhosis, advanced age, both of them are advanced age, biliary infections, and total parenteral nutrition, TPN. How can you have a stone when you're giving total parenteral nutrition? So when you give TPN, total, let me just zoom in and explain this point a bit. When you're giving, the patient is on long term on the parenteral nutrition, and you're not taking anything by mouth. So what happens is you have decrease. TPN leads to decrease in CCK release due to lack of enteric stimulation by the food, right? So CCK was getting released by the food. Food contains fat. Fat stimulates CCK. CCK would stimulate gallbladder contraction. So when you're giving total parenteral, you have a decrease in CCK. It will lead to gallstone development due to GB stone, due to hypo-GB, hypomobility. Why hypomobility leads to that? Hypomobility leads to biliary stasis, and stasis leads to GB stone. You're sitting and getting the stones. Tough thing. What else you can do? Wow. But anyways, let's continue with so that was important. What else? So most common complication in cholecystitis can also cause acute pancreatitis. So cholecystitis complication is cholelithiasis. That is the most common complication of cholecystitis. And this cholelithiasis can cause acute pancreatitis because that stone can block the main pancreatic duct, leading to acute pancreatitis or acute cholangitis. Okay. Now let's talk about this picture here. Well, let's just read from here. Diagnose with ultrasound. Treat with elective cholecystectomy if symptomatic. Elective cholecystectomy if symptomatic. The risk factors are really important. They are the 5 F's: female, fat, fertile, 40, fair. Female, fat, obesity, fertile, multiparity, 40. 40, okay. Decrease maybe mobility of the gallbladder, and fair in the whites. Okay. Let's look at this picture now. You have cholesterol stones and how they're formed, and pigmented stones. The cholesterol stones are from if you have a female sex, if you have an advanced age, and we talked about it here, obesity, genetics, and decrease in cholesterol 7-alpha hydroxylase activity. And if you remember the lectures from physiology, we mentioned how this guy leads to the formation of increased bile salts. So when you have a decrease in the cholesterol 7-alpha hydroxylase, you have a decrease in bile salts. This leads to increase in cholesterol, decreased bile salts. So you have to balance. You should have had like normal cholesterol, normal bile salts. It should have been normal. But now you have an increase in cholesterol and decrease in bile salts, and also some sort of stasis of the gallbladder. This leads to supersaturation of bile with the cholesterol, leads to cholesterol gallstones. And you cannot see them on X-ray. But the black thing, definitely you can see that on X-ray, right? So let's talk about the pigmented stone. You have the chronic hemolysis or biliary tract infection. This leads to increase in unconjugated bilirubin and gallbladder stasis. Supersaturation of bile with the calcium bilirubinate, which leads to pigmented stone, and you can see them on X-ray. Okay. That's pretty much all we have for the for the treatment. I mean, let's just a little bit touch on the treatment, as they only talked about cholecystectomy. Cholecystectomy, if symptomatic, great. But if you have high risk for surgery, if you are the high risk for surgery, or patient refuses, because you said it's elective, right? So we have the right to refuse. If refuses for surgery, then you can give some drug. Which drugs can you give? Urso deoxycholic acid. Urso deoxycholic acid. And what is that going to do? That drug is basically an hydrophilic bile acid supplement. Hydrophilic bile acid supplementation. Something else, we did talk about fibrates here. Where did we say about fibrates? Somewhere we did talk about fibrates here. So what are they gonna do? In these patients who have that, we have to use fibrates with caution. Why? Because it can cause the stones, the cholelithiasis. So anybody who has a cholelithiasis and taking fibrates, you must stop the fibrates. Now one more thing about this opioids. Administration of opioids, mu opioids like morphine. Let's just say mu opioid. Morphine. Morphine is going to cause contraction in the sphincter of Oddi. Contraction of the sphincter of Oddi, which causes spasm and increases the bile duct pressure, right? As you are contracting the sphincter of Oddi, and that's going to lead to biliary colic. Biliary colic, which is basically a severe waxing and waning pain in the right upper quadrant. And this is all due to the fact that you are given morphine. The patient doesn't have nothing. It's just normal morphine adverse effect. Okay. That's pretty much all we have for this thing. And the fibrates, if you think, one more thing here, we did talk about fibrates, but just came across one thing. Fibrates, we talk about 7-alpha-hydroxylase. Okay, fibrates inhibit this enzyme. So if they inhibit this enzyme, again we're causing decrease in bile salts. Fibrates inhibit cholesterol 7-alpha-hydroxylase. That basically let's just write it, man, so that it makes sense instead of going back to physiology. So remember, the cholesterol gets converted to bile salts by enzyme, rate limiting enzyme, which is the 7-alpha-hydroxylase. Cholesterol 7-alpha-hydroxylase. And that's that's a rate limiting enzyme for formation of bile salts. You can inhibit this thing by giving fibrates, and that's going to more precipitate more cholesterol gallstones because of cholesterol being here, leading to cholesterol stones. So use fibrates with caution in patients with pre-existing gallbladder disease. Okay. Well, on the other hand, orthodeoxycholic acid, which is the orthodeoxy, which is a bile acid supplement, bisalt supplement. If you were to give this thing, this leads to decreased amount of cholesterol secreted in the bile and increase in bile acid concentration. So basically, this guy's decreased here. So if you give the supplement, you're increasing the bile salts. So when you're increasing the bile salt, the ratio almost gets equal, and you're preventing the gallstones. And increase in bile salts concentration, which leads to improves cholesterol solubility and promotes cholesterol stone dissolution. The other thing is, one last thing, cholestyramine. This is bile acid sequestrant. What's going to happen here? If you were to give cholestyramine, you're decreasing you're decreasing reabsorption of bile acids. Reabsorption of bile acids from the terminal ileum. So that's the one thing. But second thing you're causing is increase in GB motility, which causes bile acid to be secreted out, and you're decreasing the absorption. So that's the mechanism of cholestyramine, and that's how it's helping by decreasing the bile acid reabsorption. Third thing you can also give, or fourth thing, I don't know what last account, but anything, estrogen. Remember the 40 fertile and all that estrogen. So what's the estrogen doing here? Estrogen is increasing cholesterol secretion. Okay. Increases cholesterol secretion. And on the other hand, progesterone, what do? They promote gallstones by decreasing, so the progesterone decreases GB motility. This leads to gallstones. Okay, yeah, that's pretty much all we have for the cholelithiasis.